The cardiac arrest algorithm is the most important algorithm to know for adult resuscitation. This algorithm outlines the steps for pulseless patients who don't initially respond to BLS interventions, including a first shock from an AED or manual defibrillator. Because many patients with sudden cardiac arrest demonstrate VF at some point in their arrest, it's likely that ACLS providers will frequently follow the left side of the cardiac arrest algorithm, which we'll do here. After assessing the patient, the first and most crucial step is minimally interrupted high-quality CPR. The AHA recommends the use of audio and visual feedback devices to ensure that CPR quality is maintained and optimized during a resuscitation attempt. Treatment then branches into two pathways, one for shockable rhythms, which include VF and pulseless VT, and a pathway for non-shockable rhythms, asystole or PEA. For shockable rhythms, the first step is to deliver a shock as soon as a defibrillator becomes available. The appropriate energy dose is determined by the type of defibrillator, biphasic or monophasic, and the manufacturer's recommendations. After the shock, immediately resume CPR, beginning with chest compressions. If there are available rescuers, IV or IO access should be established. After 2 minutes, or about 5 cycles, of CPR, conduct a rhythm check. Healthcare providers can perform a pulse check at the same time they're performing a rhythm check. For persistent VF or pulseless VT, give another shock and resume CPR immediately. When IV or IO access is available, give 1 milligram of epinephrine during CPR after the second shock has been delivered. Repeat epinephrine administration every 3 to 5 minutes. During resuscitation, epinephrine acts as a vasoconstrictor, which increases cerebral and coronary blood flow. Epinephrine does this by increasing mean arterial pressure and aortic diastolic pressure, which improves perfusion pressure to the brain and heart. After 2 minutes of CPR, conduct a rhythm check, being careful to minimize interruptions in chest compressions. If a rhythm check reveals a shockable rhythm, resume chest compressions while the defibrillator is charging, and then deliver another shock. Repeat chest compressions each time the defibrillator is charging. Resume CPR, beginning with chest compressions, for 2 minutes immediately after the shock. At this point, you may consider giving amiodarone, an antiarrhythmic agent that has been clinically demonstrated to improve the rate of ROSC and hospital admission in adults with refractory VF or pulseless VT. Amiodarone is a complex drug that affects sodium, potassium, and calcium channels. It has alpha-adrenergic and beta-adrenergic blocking properties, and it also blocks the actions of hormones that speed up the heart rate. The overall effect is to slow the heart. Additionally, it lowers the defibrillation threshold, making defibrillation more effective at lower energy settings. If amiodarone isn't available, lidocaine may be used. Lidocaine depresses the automaticity of Purkinje fibers, raising the stimulation threshold in the ventricular muscle fibers, which makes the ventricles less likely to fibrillate. After administering amiodarone, check for a shockable rhythm at the 2-minute mark. If one is present, return to step 5 and work through the sequence again until ROSC is achieved, at which point you'll move on to the post-cardiac arrest care algorithm. If you encounter non-shockable rhythms at step 4 or 6 and there are no signs of ROSC, go to step 10 or 11 on the asystole PEA pathway. The asystole PEA pathway is the option when the patient has a non-shockable rhythm after initial CPR. Give 1 milligram of epinephrine without interrupting CPR, repeated every 3 to 5 minutes. If the rhythm after step 10 is shockable, go to step 5 or 7. If the rhythm is non-shockable, continue CPR for 2 more minutes and attempt to treat reversible causes if these have been determined. If there are no signs of ROSC, repeat steps 10 and 11. If ROSC is established, move on to the post-cardiac arrest care algorithm. The cardiac arrest circular algorithm is another way of displaying the cardiac arrest algorithm. It summarizes the recommended sequence of actions after a cardiac arrest. It makes the point that not only is high-quality CPR performed continuously, but also CPR quality is monitored consistently. The adult immediate post-cardiac arrest care algorithm begins with ROSC. The first action is to ensure an adequate airway and support breathing immediately after ROSC. Use the lowest inspired oxygen concentration that will maintain arterial oxyhemoglobin saturation of 94% or greater. An unconscious or unresponsive patient will require an advanced airway for mechanical supportive breathing if one is not already in place. Use continuous waveform capnography to confirm and monitor correct placement of the ET tube. Avoid ventilating the patient too quickly or with too much volume. Provide one ventilation every 5 to 6 seconds. Next, treat hypotension when systolic blood pressure is less than 90. When an IV is established, hypotension may be treated with an IV fluid bolus or various drug options. A hypotensive patient should be given a fluid bolus of normal saline or lactated ringers. Vasopressors such as epinephrine and norepinephrine may be used, as well as dopamine. At this stage, consider treating any reversible causes that might have precipitated the cardiac arrest, but persist after ROSC. Obtain a 12-lead ECG as soon as possible to identify early those patients with STEMI or ECG evidence of the need for percutaneous coronary intervention. For patients with ECG evidence of STEMI or a high suspicion of AMI, attempt coronary reperfusion. ECG monitoring should continue after ROSC, during transport, and throughout ICU care until deemed clinically unnecessary. Next, examine the patient's ability to follow verbal commands. If the patient fails to follow commands, the healthcare team should consider implementing targeted temperature management protocols. After coronary reperfusion interventions, or in cases where the post-cardiac arrest patient has no ECG evidence or suspicion of MI, the healthcare team should transfer the patient to an intensive care unit. For additional information on each of the steps in the algorithms presented here, please consult the ACLS Provider Manual.